Hello, I'm Mary Vasalou. I work as a radiologist in Heraklion, Greece, and with my colleague Athena Plagou from Athens, Greece, we will go on with the second part of our talk on the shoulder's anatomy and ultrasound appearances. On this second part, we will start with the acromioclavicular joint and some acromial space along the superior, and then we will get through the posterior aspect of the shoulder. Starting with the superior aspect and the acromioclavicular joint, which reflects the articulation between the acromion on the lateral and the clavicle on the medial side. As a plain synovial joint, it has a capsule which is reinforced by the superior and inferior acromioclavicular ligaments. On ultrasound, only the superior capsule and ligament can be assessed. Let's now move to the subacromial space. This space is bordered inferiorly by the humeral head and superiorly by the coracoacromial arch. This arch is formed by the anterior one-third of the acromion, the acromioclavicular joint, the coracoacromial ligament, and the anterior aspect of the coracoid. The coracoacromial ligament is a triangular ligamentous band bridging the acromion and the lateral border of the coracoid process. The supraspinatus and long head of biceps tendons and the overlying subacromial subdeltoid bursa course within the subacromial space. In normal conditions, the supraspinatus tendon and the bursa glide smoothly beneath the arch during arm abduction. On this gross cadaveric view and schematic drawing over the lateral aspect of the shoulder, note the acromion and coracoid process joined by the coracoacromial ligament. The supraspinatus and the long head of biceps tendons and the subacromial subdeltoid bursa travel within the subacromial space above the humeral head and underneath the coracoacromial arch. Let's now go to Athena for the demonstration of the acromioclavicular joint and subacromial space on ultrasound.
Thank you, Evie. On the superior part of the shoulder, we are going to examine the acromioclavicular joint. So we place our probe on a coronal plane between the acromion and the clavicle. And here we can see the acromioclavicular joint with the superior acromioclavicular ligament on top. In order to study the stability of the joint, we can perform a dynamic maneuver where we ask the patient to move the palm to the opposite shoulder and then back again. And this is called the cross-arm maneuver. We can see that in normal situations, the two bones don't move away significantly the one from the other. Now we are going to study the subacromial space and perform the dynamic maneuver we use for studying impeachment. Here you can see the subacromial space. This is the acromion and the humeral head, and this is the subacromial space. We are going to ask the patient to actively elevate the arm to the side, and we see all the structures gliding easily beneath the acromion. We can also study the impeachment relative to the coracoacromial ligament. So here my probe is located between the coracoid process and the acromion, and we can see this small triangular structure here, the coracoacromial ligament. We are going to perform the same maneuver, try to appreciate how the structures move in this area and if they slide easily below this ligament. This is a longitudinal view of the ligament, and if I turn my probe 90 degrees, I'm going to get a transverse view of this small structure here. Now I'm going to perform the same maneuver and see how the structures below the ligament slide. I'm going to ask the patient to actively elevate the hand, and we can see how all the structures slide nicely below the coracoacromial ligament.
Thank you for that. Moving now to the posterior aspect, where we find the two remaining rotator cuff muscles, the infraspinatus and teres minor. The infraspinatus muscle takes its origin from the infraspinous fossa of the scapula and courses laterally to insert on the greater tuberosity just posterior and inferior to the supraspinatus tendon. The small teres minor muscle arises from the lateral border of the scapula and follows an oblique photocranial course to insert onto the greater tuberosity immediately posterior and inferior to the infraspinatus attachment. The spine of the scapula is used as a useful landmark to distinguish these muscles. In the schematic sagittal view focusing on the posterior aspect of the shoulder, the probe is initially placed over the palpated scapular spine. When shifted cranially, the supraspinatus muscle can be found deep to the trapezius muscle. Then, scanning caudal to the scapular spine, the infraspinatus and teres minor muscles can be identified as individual structures deep to the deltoid muscle. Note that the infraspinatus muscle has an individual aponeurosis typically located centrally, while the teres minor is characterized by the presence of an eccentrically located and superficial aponeurosis. As a variant, the muscle bellies of the infraspinatus and teres minor may appear fused, sharing a common central aponeurosis. On its long axis, the infraspinatus appears as a beak-shaped tendon coursing superficial to the posterior glenohumeral joint and posterior humeral head to insert onto the greater tuberosity. Teres minor can be seen as a thin tendon inserting on the posterior aspect of the greater tuberosity. On their short axis, the infraspinatus and teres minor tendons are seen along the posterior aspect of the greater tuberosity. When scanning laterally, their insertion on the middle and inferior facet respectively can be appreciated. Please remember that in some patients these tendons appear to merge in a single tendon at their insertional level, thus it may be difficult to identify them as separate structures. In the posterior aspect, the posterior glenohumeral joint recess should also be evaluated. This recess is delimited by the posterior humeral head and posterior bony glenoid and labrum on the lateral and medial side respectively, while the myotendinous junction and tendon of infraspinatus lie just superficially. Medially to the joint recess, the suprascapular nerve and accompanying artery are located within the spinoglenoid notch, but this is going to be discussed in detail later on. As a final step, the suprascapular and spinoglenoid notches should be assessed. These sites represent the bony landmarks and the ultrasonographic identification of the suprascapular nerve along its course. The suprascapular notch is a shallow concavity of the scapula located medial to the superior labrum and glenoid and deep to the supraspinatus muscle, while it is bounded by the suprascapular ligament. The suprascapular nerve is located within the notch, accompanied by the suprascapular artery. Note that typically the nerve travels deep and the artery superficial to the ligament. The spinoglenoid notch is a falc-filled osseous groove located medial to the posterior labrum and glenoid and deep to the infraspinatus muscle. The suprascapular nerve paired with the suprascapular artery are located within the notch, bounded by the spinoglenoid ligament. We will get back to Athena now for the demonstration of the posterior shoulder on ultrasound.
Now we are going to scan the posterior part of the shoulder. The examiner is standing behind the patient. We are going to use a sagittal plane to evaluate first of all the muscles. So I'm placing my transducer on the supraspinous fossa here, which is proximal to the spine of the scapula. So here we can appreciate the trapezius muscle and the supraspinatus muscle, we have to compare the echogenicity of the two muscles to make sure there is no muscle atrophy or there is no loss of muscle volume. After we scan the supraspinatus muscle, we move downwards. Again, the spine of the scapula is our landmark, and we're going to move more distally to study the infraspinatus and teres minor muscles. Here we can see the infraspinatus muscle and the teres minor lying below the deltoid muscle. Again, we have to compare the echogenicity of the three muscles and appreciate the muscle volume. The next structure we're going to study in the posterior aspect of the shoulder are the tendons of the infraspinatus and teres minor muscles. Moving from the sagittal plane to a transverse plane, we can appreciate the central aponeurosis of the infraspinatus muscle, which forms the infraspinatus tendon that inserts on the greater tuberosity. If we move a little bit more caudally, then we can find the tendon of the teres minor muscle. Now we are going to use the infraspinatus tendon as a landmark. Here we can see the infraspinatus tendon, and below the tendon we can find the posterior glenohumeral joint recess. Here we can look for fluid in the joint space, and we can also appreciate the triangularly shaped posterior glenoid labrum here. Now in the supraspinous fossa we are going to look for the suprascapular nerve. A good landmark is the suprascapular artery and veins, and next to them you can find the suprascapular nerve lying deep to the supraspinatus muscle. As I move in the infraspinous fossa, I'm going to look in the sagittal plane for the spinoglenoid notch, which is this area here filled with fat, vessels, and the suprascapular nerve in this position. Using the color Doppler again, we can study the vessels and the spinoglenoid notch, where we can look for paralabral cysts and sites of compression of the suprascapular nerve.
To conclude, in the second part of our shoulder anatomy demo, we demonstrated the dynamic maneuvers that are frequently used during a routine shoulder examination. We evaluated the ultrasound appearances of infraspinatus and teres minor tendons using a posterior approach, and demonstrated the structures that can be studied with ultrasound in the posterior aspect, such as the posterior glenohumeral joint recess and the suprascapular and spinal glenoid notches. I hope you enjoyed it. On behalf of Evie and myself, thank you very much for listening.